Thank you to one of the series of second Wednesday night Healthcare for All Washington webinars. This is one of a series. We've covered a variety of topics, including healthcare financing, healthcare legislation, equity, Indian health. And tonight's talk is going to address mental health challenges in our state. My name again is Peter Lucas. I'm a board member and I'll be the moderator tonight. But let's break the ice a little by having you all identify yourselves in the chat and state your location and the reasons for attending this webinar. And if you're so inclined, please tell us how you heard about Healthcare for All Washington. Kind of like to know where everybody's coming from and how they know about us. So if you can just post that in the chat. So now, presentation will be about 30 minutes. If the presentation stimulates questions you would like answered during the Q&A portion, please post them in the chat as well. And as a practicing psychiatrist, I'm especially eager to learn from tonight's speaker, Katherine Seibel, whose talk is entitled NAMI Washington Advocacy 2021 Recap and Looking Forward to 2022. Katherine's going to introduce herself and then make her presentation. As I say, it'll be about 30 minutes, be followed by at least 10 minutes of question and answers. So I'm looking forward to a stimulating presentation and discussion. So go ahead, Katherine.
Wonderful. Thank you so much, Peter. And hello, good evening, everyone. It's really wonderful to be here with you all tonight. So thank you for having me. Like Peter said, my name is Katherine Seibel. I use she, her pronouns, and I'm currently the Director of Public Policy and Advocacy at the National Alliance on Mental Illness, Washington. I got started in my career as a counselor at the residential and partial hospitalization levels of care, where I focused on DBT, mindfulness, and trauma-informed yoga, among other things. I got my Master's of Science in Social Work from Columbia University, focused in public policy. And from that time forward, I've really been involved in multi-state and federal level policy and advocacy efforts around mental health, social emotional learning, child sexual abuse prevention, and bullying prevention, to name a few. And I've also currently served as a teaching associate at Columbia University. So it's a little bit of background about me. And again, I'm really excited to be here with you all. So with the time that I have with you all tonight, I'm planning to talk a little bit about NAMI Washington as an introduction, just to have some grounding information so you know where I'm coming from and how this shades our advocacy and policy efforts at the state level. I'll talk just a little bit about the context for mental health in Washington and in our country. I'll give a rundown on the 2021 legislative session and interim updates. There's quite a few things that have had really substantial changes for behavioral health in our state. And then I'll chat just a little bit about looking into 2022. And like Peter said, I'm so happy to take questions. So please put those in the chat and I'll look forward to answering them after speaking. So ready for next slide. Great, and if you could, oh, perfect, thank you. So the National Alliance on Mental Illness, which you'll hear me say NAMI, got its beginning in 1979, and it began because of a need. There were families and people affected by mental health conditions that were unable to find care. They turned to each other ultimately and created informal groups to share information, offer support, and work together to fight for fair treatment. And these families really saw potential in grassroots organizing and then created a movement from this work. So today, NAMI is the nation's largest mental health organization to include people living with mental health conditions and their families. And the goal ultimately is to improve the lives of people impacted by mental illness. And we do this through advocacy, education, and support. Awesome, thank you. And I'd like to show this slide again to kind of help with the grounding of the way our organization is structured. So NAMI has a national office, and for advocacy and policy purposes, they focus on the federal level. Then each state has a state chapter. So I'm with NAMI Washington in our state, and then each state has affiliates. And ultimately, we're composed of tens of thousands of individuals and families who are impacted by mental illness. So what is NAMI Washington? As I mentioned, it's the state chapter of the National Alliance. In our state, we have 19 affiliates that provide free, open to the public resources, support groups, and education programs. And at the state level, our policy and advocacy work is really informed by our engagement with our members who come from all across the state. And again, I really like this infographic to show where our affiliates are located geographically across our state. And I want to point out right now, so our affiliates offer programs, resources, education, and because everything's online, maybe I can put this into the chat after I'm done speaking, but you are welcome to, if you would find this as a resource or are looking to gain support, you can join groups and seek resources from any one of our affiliates, again, because it's free and open to the public. So I'll be sure to put that in the chat after. Next slide, please. So now we have a little bit of background around NAMI Washington and what we do, and let's talk a little bit about the context for mental health care and conditions in our country and in our state. So prior to COVID-19, we knew that 1 in 5 adults experience mental illness, and 1 in 6 US youth aged 6 to 17 experience a mental health disorder, and suicide is the second leading cause of death among people aged 10 to 34. And so given this prevalence, I find it really important to point out that there's a huge delay in getting to care. The average delay between onset of mental illness symptoms and treatment is 11 years. Next slide. Thank you. And so we might all be really readily aware that COVID has had really significant impacts on our mental health for adults and young people alike. 21% of US adults had high levels of psychological distress at the pandemic's 1-year mark. There have been increases in children and youth mental health conditions and need for acute psychiatric care. One statistic is some hospitals have seen a 67% increase of youth with mental health conditions, and that's just one. There's so much data here, and the evidence is growing, but a really great need. And then to point out that people with previous diagnosis of mood disorder have been found to have higher risk of mortality from COVID-19. And access to care is one of the key issues I want to highlight here. So more than half of Americans have reported that COVID-19 has had a negative impact on their mental health. And in February of 2021, just about 50% of adults in Washington who reported symptoms of anxiety or depression, 30% of these folks were unable to get the needed counseling or therapy. So of over 400,000 adults in Washington who did not receive needed mental health care, 36% did not because of cost, and this is just really astounding. So we sent out a recent survey back in August to further examine experiences around access to mental health care from Washingtonians, and respondents reported these takeaways with challenges to accessing mental health care in our state. So as you might imagine, it took too long to get the right kind of mental health care, and this is inclusive of during times of crisis. Finding the right provider to meet a person's needs, especially in rural areas, and especially finding a Black, Indigenous, or person of color provider was often extremely challenging. And then the final really big challenge was cost and insurance adequately covering the needed services, which were really significant barriers. And I think in sum from this survey, essentially respondents successfully accessing care could be summarized as finding the right service, getting to it at the right time, and being able to afford it or that their insurance adequately covered it. So I want to acknowledge that to me, this feels really, really heavy, and that there's a lot of work to do. And I also want to acknowledge that there have been huge strides that have been made to move our system and our state forward, and that our system is shifting. So with the time that I have, I'm going to highlight some of the key changes that came from 2021 and the impact on our behavioral health system. But again, I really want to acknowledge that there is so much that happened in 2021 that directly impacts people living with mental health conditions, and so much to talk about. So I'm just going to focus on a few key highlights for this evening. So the first highlight is the passage of HB 1086. And our guess is that this bill will impact over 1.5 million people to better access services in our behavioral health care system. So what does this do? It establishes a new statewide office that streamlines the point of access to regional behavioral health ombuds services. So this means it will make accessing, they'll make the services that these offices more accessible for folks all over our state to get help with getting connected to advocacy services that they provide. And this would be identifying and resolving complaints that they might have about care, or getting information about their rights, or seeking assistance with things like finding or changing providers, and making sure services were paid for, are just a few examples. It also empowers advocates to serve as a patient advocate for individuals who are in psychiatric units and hospitals, to ensure that patients are receiving appropriate treatment and that their legal rights are being respected. And finally, a really key piece of this legislation is that the office will play a role in providing feedback to the legislature and accountability for improvement in our systems change. So where does this stand now? The transition to the state office will be in 2022. So the Healthcare Authority and the Department of Commerce are working on implementation, and stakeholder input on naming the office is ongoing and available via this survey link, though I also don't have it up, so I'm gonna have to put these links in the chat afterwards. Next slide. Another huge highlight that I wanna raise is the passage of HB 1477. So this bill lays the framework for calling the 988 crisis hotline for behavioral health crises and suicide prevention. And this would be an alternative to calling 911. It established a crisis response improvement strategy committee, which I'll talk about a little bit later on the next slide. And this committee will help make recommendations and address all those nuts and bolts that come with this implementation and planning for the number and the needed response services. And it also provides for attacks on phone lines, for routing the 988 calls and directly responding to the crisis line. So implementation is just beginning, and I think it's really exciting. There have been stakeholder meetings convened by DOH as a part of the Vibrant Planning Grant. And those stakeholder meetings have since wrapped up, and this work will produce a landscape analysis around the operational realities of the Suicide Prevention Lifeline, and then it will also provide some implementation recommendations that will go to the CRIS committee. And so the CRIS committee, this again, I'm sorry for using the acronym, Crisis Response Improvement Strategy Committee, has just begun meeting, and they had their first full committee meeting in September last month. And there is information on the committee on the Healthcare Authority's website. So this might be if you're looking to view the meetings or submit public comment or looking to engage in some of the efforts that will be forthcoming, I would definitely check out that website. It's a great source of information. And finally, I'll note that the Office of the Insurance Commission is accepting public comment on rulemaking for the CR 102 on next day appointments that was provided for in HB 1477. And there will be a public hearing on this next month. So all things upon your radar, and I think exciting steps forward on this front. Now, in talking about crisis response, I think it's also really important to talk about changes to police accountability that have been happening in our state. And there are a number of bills that passed in 2021 that have impacted police accountability. And strengthening police accountability is important when we think about the intersection of our crisis system, policing, and behavioral health, and the deadly and harmful disproportionate impacts that it has on communities of color. By the most conservative estimates, at least 1 in 4 fatal law enforcement encounters involve an individual with serious mental illness. So the bills I want to highlight for you today are HB 1054, which bans chokeholds and neck restraints, HB 1267, which creates an independent office to investigate deadly use of force, SB 5051, which strengthens accountability and oversight measures for law enforcement, and then HB 1310, which would requires police officers to use reasonable care when exercising use of force and to use appropriate de-escalation strategies. So where do these bills stand right now? Just a few quick updates. The ban on chokeholds and neck restraints became effective this year. The independent office will begin investigations in July of 2022. And the CJTC, Commission for Justice Training Commission. I'm sorry, I'm not getting that right. It's been a long day. We'll develop policies, procedures, and rules by June of 2022 to ensure that the goals of 5051 are implemented. And then chatting a little bit about HB 1310, it became effective this year, and it's something we've been really concerned about because there have been varying law enforcement agencies' responses to this law. such as not responding to a mental health crisis call. And this has been really harmful for people who are experiencing a mental health crisis. We've made a statement about it, and are collecting experiences of police not responding to mental health crises. So with that, we can uplift this in state advocacy. And so if you have been impacted and would like to share your story with me, I'll also put my email in the chat later and welcome a connection as well. And then the final note that I'll say about this is that the Attorney General came out with a memo earlier in the summer acknowledging that 1310 does not prohibit law enforcement from responding to behavioral health crisis calls, though we are still awaiting a formal opinion. Finally, from 2021, I want to highlight the new investments in the past operating budget. There were increased investments in behavioral health and in housing, such as permanent supportive housing and peer support. And this is so integral and vital to promoting mental health and wellness. And I want to emphasize this here, that the historic investments in housing are so important when we think about the intersection of behavioral health, because 1 in 5 people experiencing homelessness have a serious mental health condition. And so strengthening and expanding this basic need is a huge component of supporting and promoting mental health and well-being for everyone in our state. So as I said, there was a lot that happened and I didn't get to nearly cover everything. I have a full legislative report on NAMI Washington's website, which you're welcome to check out, and I can share in the chat as well. So now let's, with all those changes happening, let's start to think about 2022. So as you might already know, the legislature will have a short session, just 60 days, which it starts in January. And NAMI Washington is still working on setting our formal legislative agenda. But I'm happy to share some of the key issues that we're thinking about for the upcoming session. So I think the first main bucket is access to care. It's really important to strengthen and invest in services at every level of care, so that's also accessible across our entire state. This could include further strengthening outpatient programs or ensuring equitable access to needed medications. So those are a few things under care access. The next one is workforce. So growing and supporting our state's workforce crisis in the field is also a really vital component to ensuring people are able to access the services they need, especially in thinking about people in rural areas needing to access care as just one example. And then finally, continuing to strengthen the behavioral health crisis response. So it is really critical to ensure that our crisis response system continues to move forward. There are so many changes coming, and there's a lot of momentum behind this work. And we also need to ensure that crisis responders are able to appropriately respond to mental health crisis calls. So how can you get involved if this sounds interesting to you? Through this link, you're able to sign up for NAMI Washington's advocacy communications. There will be a form on that website. So signing up means you'll receive action alerts and legislative updates and information on our annual lobby day. You're welcome to attend a SMARTS workshop. I didn't talk about this when I was talking about NAMI Washington, but we offer a thing called NAMI SMARTS, which is multiple workshops on how to engage in advocacy. And the ones we'll be hosting are how to tell your story. And so those will be the first Tuesday evening of each month. So we have 2 more in November and December. Again, this information is on our website. And then I also want to highlight that we have online support groups and resources that you're welcome to connect with at any time. And finally, again, at NAMI Washington, our focus and scope is at the state level, but if you're curious about mental health policy and advocacy, you can certainly connect with NAMI National, and I have a link there. So I'm happy to put this all in the chat in a moment. I think that might be my last slide. I'm happy to take questions.
So Katherine, first of all, thank you so much for speaking to us. Your organization has a very near and dear place in my heart. Barbara Bick was one of the founders, and she was a dear friend of our family. Her daughter was schizophrenic in Washington, D.C. She was also the founder of St. Elizabeth's, Friends of St. E's, as well as Women's Strike for Peace. So I came across, in preparation for your talk tonight, I was just doing a little bit of research, and I came across this Marshall Project article that talked about this California program called ConRep. It's in the chat, which oversees Californians, who have been warehoused, to try and through the process of releasing them. And the Marshall Project investigation pointed out, and it's really a heartbreaking read. I was almost weeping as I was reading it. It literally leaves people in decades in a legal limbo, literally for decades. And I was wondering, here in Washington State, what is our protocol for releasing those who have been warehoused in jails?
Yeah, so I think the Marshall Project does a really great job of reporting. And by warehousing, do you mean that people looking who have had mental health symptoms and have been then taken to jail rather than
exactly, that they're incarcerated as opposed to treated?
Yeah, it's a really big question. I think that's something our state is still really grappling with. And I think this is there's so many ways to answer this as well, because I think jails have become a place that people go because there is a great lack of infrastructure and appropriate diversion. And I think these efforts really need to be expanded. There also, once someone is incarcerated, that we know that getting appropriate treatment is extremely challenging. And so then through the reentry process, this again has also been just a place where a lot of people are not connected to the appropriate services that they need. I will say there are two bills that I was excited about that passed in 2021. One is 1348, if I'm getting the number right, which would prohibit someone's Medicaid from turning off within the 29 days that they become incarcerated. And that's important because then it helps to increase the continuity of care while they're in jail and through the reentry process to be able to still get services that they need. But I think to your question, it's a really important point of focus that the state still needs to continue to work on. Oh, you're muted.
As a very quick follow-up, we as Healthcare for All Washington, who are focusing on universal health care, how should we advocate, and how do you recommend or counsel us to advocate for this in a universal health care package in Washington State?
Yeah, I think that's a great one, and another a really big one as well. And I think I welcome any opportunity to collaborate and cross advocate and share information, certainly.
Okay, so now I'm asking questions for other folks.
I just wanted to call on David McLanahan. He's had his hand raised this whole time, so I just wanted to make sure he got a chance to ask his question.
Thanks. Well, maybe the previous answer answered it a little bit, but I saw recently that lots of mental health providers are not taking insurance because of the hassle and the low compensation for their work they're getting from the insurance companies. So I was wondering if NAMI was doing anything to push for national Medicare for all, a la Pramila Jayapal's bill. Are you doing anything as far as lobbying legislators along that line?
So I can't speak for our national office, though I am sure that might be something that our national office is working on. But again, our scopes are limited, so I can only focus on the state level efforts. But I'm happy to check in with national and see what their status is on that. So that would fall to their office. You said something though that reminded. Right. I mean, I think it's an incredible issue that really speaks to the workforce crisis that we're facing in our state. That rates are low, and then there's also quite a bit around certification, and so I think it's a quite a multi-layered issue that I think it's also something we're very aware of and hoping to support.
David Loud, would you like to go? David, you're muted.
Yes, thank you. Thank you, Katherine. Wonderful presentation, very helpful. Can you give us something of an update on the issue of parity, which both in federal and state law has in principle been in place, where mental health and physical health are treated the same by insurance coverage. But the last I heard from folks in the field, we're a long way from parity, in fact. Mm-hmm. Can you tell us something about that?
Of course. Yeah, thank you for asking. And I think it's a interesting challenge, and just speaks to the insurance coverage is only one piece of the problem. But I think we often find, and a lot of our members experience this, that care is not integrated. And I think this also speaks to some of the workforce challenges that we have. And providers not being adequately trained or prepared to deal with some of the needs that when someone comes in to seek care. So I think that might be one of the issues, but even though with the parity happening, I think in practice it's much more challenging, and folks are facing those experiences like you mentioned.
Well, excuse me, just a follow-up point. My impression is that a lot of the insurance carriers are pretty good at gaming the system so that they can avoid their responsibilities to provide parity in coverage.
Mm-hmm. Mm-hmm. Yeah, I think it's an important thing to look into. And I think, again, looking at network adequacy is very critical.
Okay, let's see. Consuelo, oh, sorry, Consuelo, you're muted.
Yeah, I'm sorry, I was having I couldn't unmute myself. Sorry about that. I would like to ask a question from Peter Lucas, and he asks, has the ACA brought about any significant improvements in mental health care in our state?
Yeah, I think it has contributed to helping to get people covered, though I think it's not the entire answer. I think there's still barriers to accessing care, and this stems from a variety of reasons, whether it be dealing with navigating the criminal legal system and our crisis response system as it currently stands, or knowing where and what services to ask for. I think there's quite a few elements to that as well, but I think indeed it has helped.
Gigi, do you want to ask your question?
Oh, the one I wrote in the chat right here.
Yeah.
Yeah, sure. This is actually my boyfriend's question. So if you could design a diversion program to address low-level mental health issues that land people in the criminal justice system, what would it look like? Or basically, like, what are the biggest holes in the current diversion program for people with mental health issues?
Yeah, that's a great question. If I could design a policy, I think the first thing would be making sure that preventative care and resources were adequately and equitably distributed and accessible. I think part of that too is ensuring that there is also a great deal of a continuum of preventative care, so that people don't have to reach a crisis point. Then I think when someone does reach a crisis point, that might involve need for diversion, having people that can respond with a trauma-informed approach, that we have the adequate infrastructure to get people to the right kind of service that they need for the experience that they're having, and to ultimately have it be services away from the criminal legal system.
This is a question from Al B. What is the situation with helping parents of adult children who are trying to help them? There is a little support that I see in this issue.
I'm so sorry. Can you say that one more time?
Absolutely. What is the situation with helping parents of adult children who I assume are suffering from mental health issues who are trying to help them?
Mm-hmm.
What kind of support is available for parents?
Mm-hmm. Yeah, I think it, I'm not sure if I can adequately answer this question because I think it depends on the context and the kind of support that is needed. And the dynamics. I think there are, yeah, again, I think it does depend on the situation. And I know I can answer at NAMI, we offer support groups and peer-to-peer resources if that is of support. But I think there it also kind of depends on context and need as well.
Gigi, you want to take Liz's question?
Oh yeah, sure. I was just looking at that. So Liz posted a question. So is there, and it's kind of similar to some of the other ones, but is there any discussion of funding programs that provide counselors who visit people who are resistant to intervention/treatment in person? And then, yeah, she describes a personal situation where she says, after 3 hospitalizations and a few months in jail, my friend's son with bipolar, I was finally engaged when a counselor visited him once or twice a day, brought him meds, took him for walks and other fun activities. Then he fell through the cracks when the program ended. He stopped taking meds, did not follow through, is currently experiencing a manic episode that doesn't quite rise to the level of involuntary commitment, according to the crisis responders who have visited him.
Mm-hmm. Yeah, that's a really great question. And I think points to one of the things that I think lawmakers are looking at is assisted outpatient treatment and strengthening that in our state. Right now, there are 2 pilot programs, but that could certainly be a resource to expand that continuum of care and added support for people who need help getting to treatment. So that is the first thing that comes to mind for me.
And in that, I'm not sure. I think we asked this, but I just wanted to make sure. Did we ask about Peter Lucas's second question about eliminating cost sharing, lack of insurance, and underinsurance, and what is NAMI's policies doing to reduce those barriers?
I do not see that question. I don't think we talked about it yet. Nice. Could you repeat it, please?
Absolutely. So what is NAMI doing to reduce barriers to care, such as reducing or eliminating cost sharing, lack of insurance, or underinsurance?
Mm-hmm. Yeah, these are all really good questions. And I think on the insurance side of things, because our scope is limited and we have minimal capacity, it is not something that we have been acting on as much as I would like to. And so I think there's a lot of opportunity to continue to work on that, certainly. But I think because there are so many issues that fall under the realm of behavioral health, I think that's been one that we have been able to address less of.
Thank you. Archie, do you have a question?
Yeah, I just typed a shortened version of it, but I guess my point is that, all the, insurance coverage or Medicaid coverage or Medicare coverage isn't going to do any good if the providers aren't out there. I've had clients who have searched for months for a psychiatrist who could prescribe medications, for psychologists, and now right now I have a waiting list for clients to come in to see me as a mental health counselor.
Mm-hmm.
So I guess partly I have something to add to that afterwards, but do you know of any efforts to get more trained professionals out in the field?
Yeah, no, I really appreciate your comment. And I think it's just something I continuously see is that when I think about building infrastructure, covered all these things, it's so dependent and critical on expanding and supporting our workforce. So I believe the UW has efforts in the work to work on expanding, I believe, and incentivize social work students, though I think that work might be on hold, so I can't fully speak to that, but I think there are a couple of groups in our state that is a big priority for them.
Okay, yeah, because I was going to add, because I was just in a meeting actually a couple hours ago with a group from Sound Alliance, and apparently there is a King County provided a bunch of funding to start a program, hopefully this coming year, to start an internship program to get people in on a very entry level positions, but it still doesn't seem like it's going to be nearly enough.
Yeah, I agree. I also think this is this issue also really intersects with thinking about like student loan forgiveness and incentivizing certain professions to come into the field that have a high cost with the education that we have in place. So I think also looking at federal levels here too is really important.
Let me add a second point about Medicare. As a mental health counselor, Medicare won't pay for my services. At a master's level, I get dozens of people over the years with Medicare coverage, and that includes Medigap plans, Medicare Advantage. With the changes to Medicare, hopefully coming down the road, that's something that needs to be changed.
Mm-hmm. Yeah, definitely.
Catherine, there was following up on Archie's point, there was a program that the state had when they were trying to get entry-level teachers about 20 years ago that allowed for Seattle U to do a special program that was not accepted in other states by and large by teachers unions, but was available here. And I know my older son went through the program and actually got a teaching certificate through Seattle U at that point as part of that program to try to put more teachers out into the field because they recognize the shortage of grade school teachers, for example, in elementary and middle school teachers. Perhaps there's some way that you could look at a possible program to get mental health professionals certified at a relatively entry-level basis through Seattle U and other places like that have been involved in these programs in the past to get more mental health professionals, especially in rural areas, to get them out and into the fray, because here in the Olympic Peninsula, for example, shortage of mental health professionals, especially patients up here.
Yeah, absolutely. I completely agree. I do know, I think there is being some, but I don't have all the information on that.
David Lord has been waiting patiently to ask his question. I'm so sorry.
I wasn't waiting very long. No. This is a follow-up question to Archie, and that is one of the provisions in Pramila Jayapal's Medicare for All bill, HR 1976, is that it would, in fact, establish Medicare coverage for you and for the other mental health professionals who are currently not covered by Medicare. So that's just one point. The other thing I was going to say is we have a tremendous opportunity in front of us this coming year, this coming couple of years perhaps, in Washington State, with the startup of our new permanent Universal Healthcare Commission. And I know Katherine has done a nice job participating in the policy committee of our larger coalition, Healthcare is Human Right, that Healthcare for All has been an active participant in. And I'm hoping that NAMI will find a way of engaging with the work of the Universal Healthcare Commission to address a lot of the issues that we're talking about today.
Yeah, thank you, David. I see, Consuelo, I see a great question in the chat. Is it okay if I read it, or will it?
Absolutely, please do.
So this one says, school counseling as an early intervention, a number of bills pop up to increase and improve access. What is NAMI's position, potential value of school-based health centers that include counseling? I think this is a great question, and something that I personally feel really passionately about, because I think having access to counseling and mental health services within schools is a huge gateway to getting support and services. So I think that's something NAMI would be deeply supportive of. And I think too, with that, I mean, it makes me think of evidence-based social emotional learning and getting access to those really foundational skills in schools, and offering support to kids through that mechanism. So I appreciate that question.
So this is from Dana or Dana. I'm sorry, I'm not sure how to pronounce. How many patients who need mental health care are without primary care providers? And perhaps people in the audience, such as Archie or David and Peter, might be also able to address that.
Yeah, I don't have the answer to that right off the top, but if others do, please jump in.
The docs in the room.
Well, just anecdotally, I have a number of patients, especially low-income patients, who seem to have quite a bit of difficulty accessing primary care. They have long waits. There's, they're not, primary care physicians are not taking new patients. Primary care docs, for the most part, are paid on the lower end of the pay scale, like psychiatrists. And so therefore there aren't enough people who go into that field of primary care, especially in the public sector. So yeah, it's an issue across the whole healthcare system, not just mental health. So we can take another question or two if there's anything really burning.
Consuelo, tell me if you.
No, jump in, because
Okay.
I'm scrolling through seeing what we missed. Jump in, please.
So another one I see is, how has COVID affected telecare and mental health?
Yes.
And is it a good thing? Yeah, I think there has certainly been a huge increase in accessing telehealth healthcare services. And it offers a lot of opportunity to connect to care if someone isn't geographically in the same position or same location as a provider who'd be able to offer them the service. Though I also will say, I think it also speaks to thinking about equity issues and accessing broadband, and being able to have access to technology also brings up certainly equity issues, but I think at the same time, it still offers an increase to accessing care.
Yeah, do we have any further questions? Okay. Well, I know Katherine needs to sign off soon. I really want to thank you for coming and doing this presentation and taking all these questions out of right and left field. You were able to answer them all quite well. And we really appreciate what you and NAMI are doing to help mental health care in our state. And you're definitely involved in a lot of different things. We do hope maybe you will get more involved in the economic issues in terms of, paying for services, insurance, underinsurance, those kinds, co-pays, those kinds of things. So we hope that that's the direction that NAMI will eventually, take on. So thank you so much for coming.
Great. Thank you so much for having me. It's been wonderful to be here with you all. Thank you. Bye.
Did she leave?
Yes.
Oh, will we have access to the slides?
I've got, I'll get her permission. I have them.
Okay.
I have them on my computer. I'll just make sure I get her permission.
Because it'd be great to post them on our site.
Good. Well, we heard about what NAMI's doing to address various problems and deficiencies. Katherine identified some of the barriers to mental health care in our state, such as limited access to care. I think she said that 30% of people recently just couldn't get any care at all in our state. She also said that the cost is a major barrier to getting care, and that patients often have difficulty finding providers. So I just want to share a couple of slides to kind of address this, and why we think, I have to put in a plug for our organization and for single payer. That is our raison d'etre. Healthcare for All Washington wants to see single payer healthcare in Washington State. We've been working on it for many years. We made some progress. We're not all the way there. We're hoping that the Universal Healthcare Commission that was mentioned earlier will get us further down that road to establishing universal, publicly funded healthcare in our state. But let me just share my screen here. Show you those slides. So can you all see what I've got on my screen?
Yes, we can see it.
Good, good. So, why do we think? Oh, let me do the slideshow here. That's not what I want. So why do we think single payer for all would address some of these issues that I've just mentioned and that Katherine spoke about? Well, one of the things we talked about is lack of providers and also choice of providers. Commercial insurance often has limited networks that patients just can't access. Often the information in them is inaccurate, and they make call after call after call and can't find a provider, a therapist, a psychologist, or a psychiatrist who can treat them. So single payer would provide coverage and free choice of every hospital and provider. In other words, every provider would be in network. Number two, treatment costs. Is a big barrier, and with co-payments, deductibles, co-insurance, people often don't seek care because they just can't afford it, even if they have insurance. This is the problem of underinsurance. So people forego care because they're afraid of getting socked with some big bills. A single payer system would provide full coverage with no co-pays or deductibles. Prescription drug costs, another barrier to care. Formularies, which are restricted choice of medications that providers can prescribe. There are various tiers. Some medications that are very critical for a particular patient have very large copays, and therefore patients don't take them. In a single payer system, prescription drugs would be covered with no copays or deductibles. Continuation of care. Because patients often have their insurance tied to their jobs, when they lose their job, they lose their therapist or their psychiatrist, and because they're in a different network, and therefore there's this lack of continuity of care, and they sort of have to start all over again. Under single payer, coverage stays with you for life because you can see any provider. So healthcare for all means mental health care for all. A single payer system covers everybody for all medically necessary care, including prescriptions and services for behavioral and mental health and substance use disorders. Lifelong, no interruptions, no copays, no deductibles. Free choice of hospitals and providers, including psychiatrists, psychologists, and licensed counselors. So it's time to invest in our mental health. It's time for healthcare for all, or as we say, everybody in, nobody out. So I also want to just let you know that as an organization, we have needs to keep our operations going, to fund our various endeavors. And we've chalked up a lot of successes in the past few legislative sessions, and that's been facilitated by the support we received from members and donors. We were the driving force behind the Universal Healthcare Work Group. We had 7 members in that group. That group led to the creation of the Universal Healthcare Commission, which is in the process of getting established, which is tasked with designing and implementing, or tasked with designing a system to provide universal healthcare in our state. So in order to keep this process going and promote it, we need to maintain our momentum. We need to grow our membership, educate the public, mobilize our supporters to spread the word to their family, friends, and most importantly, their legislators. And we achieve these goals through social media, monthly webinars like the one tonight, meetings with civic groups, and by hosting other events. And we hope in the future, as COVID, let's hope it's actually starting to die down. We hope to get out from behind our laptops and have more in-person events. Now we have a paid employee and other fixed costs, and that those activities require funds. And we have a lobbyist who comes in prior to the legislative session, legislative sessions, and works diligently through the session. We'd like to have her return this year in 2022 to help us in Olympia to promote our legislation. So tonight we'd like to raise $300, and the way you can donate is to go to our website and click the donate button. There's also a link in the chat where you can do that, and you can make a one-time donation. You can also, and we would appreciate monthly donations with good steady support month after month. I liken it to a Netflix subscription, except you get universal healthcare instead of movies. So please donate so we can spread the word and bring about universal single-payer healthcare in Washington. And I'd like to turn it over to our esteemed president, Marcia Stedman, who's been with us for many years and really knows our organization. And she's going to talk to you a little bit about our annual meeting, which is coming up next month. Marcia, are you there?
There we go. Hello, everyone. Thank you for staying with us here. It's a wonderful program. I'm glad you were able to hear it and see it. So we've got to save the date. So our November virtual meeting, our second Wednesday meeting will not happen. It will be happening on the second Saturday in the afternoon, November 13th from 2 to 4 p.m. It will be virtual, and it will be featuring Dr. Stephen Campbell, who will speak on the topic of financing universal healthcare through global budgeting. Or, to be more specific, this is something he floated to me today: insurance industry Trojan horses. What's wrong with HMOs, ACOs, DCEs, Medicare Advantage, and Medicaid managed care? So hopefully he'll answer that for us on November 13th. But Dr. Campbell actually is a psychiatrist as well, and he's a psychiatrist in private practice. He also teaches psychiatric aspects of general medical care to internal medicine residents. He has a long-standing interest in healthcare reform and has been appointed to the Hawaii Health Authority and the body in charge with overall health planning for the state of Hawaii, and that body with designing a universal healthcare system for covering everyone in the state of Hawaii. A healthcare financing expert, Steve is also a clear and engaging speaker. As you know, the actuarial studies done for the Universal Healthcare Work Group last year showed that publicly funded universal healthcare would save the state billions of dollars every year in healthcare spending. But is it feasible? Well, by addressing the good, the bad, and the ugly of the healthcare financing schemes out there, Steve will give you the background you need to understand and talk about the most financially feasible way to achieve those savings while giving everyone the healthcare they need. Hint, it's not any of those Trojan horses. So please plan now to join us for an exciting program, plus a review of our 2021 healthcare legislative successes, a look ahead at what we plan for 2022, and more opportunities to support our ongoing work. The brief business meeting will include votes on Healthcare for All Washington's proposed 2022 budget and the election of directors and officers for the coming year. If you're new to us, please join by October 29th so you can vote on these important issues. It's easy to join online at our donation page at www.healthcareforallwa.org, donate, and at the link in chat. See you next month, Saturday, November 13th, and more details will be coming soon. Thank you for joining us tonight.